Let's talk about olfactory loss. And this is probably I think I presented to this group 5 or 6 times over the last 5 or 6 years. And this, I believe, is the first talk that I'll give without any surgical videos or any real discussion about sinus surgery. I am a rhinologist, so all I do is treat patients with sinus and other nasal disorders. I don't really do any ear work or throat work, haven't for many, many years. So why is, just a couple disclosures here. Really the only one that would apply to this talk is my AstraZeneca research consultant role, if we get to that part of the discussion, but nothing related to olfactory loss. So why is a rhinologist, a sinus surgeon, talking about olfactory loss, and how did I get into this? Well, it happened early in my academic career. The original Zicam, which is a zinc-based, or was a zinc-based nasal spray that claimed, if you can read this, get over your cold faster. And the company made claims that using a Zicam spray with upper respiratory infections would decrease the duration of the cold. And there were reports of patients losing their sense of smell and having intense burning after using Zicam. So a lab at the UW I was working with, we decided to study this. And in patients that I was doing surgery on, we would harvest some tissue and run it. Literally, I had one of my residents run it 10 minutes down the longest hallway west of the Mississippi to the research lab. And they would use a electroolfactogram, where you can actually, the tissue kind of stays alive for about 20 to 30 minutes after you harvest it. And if you put the right probes in, it will detect if an odor is sprayed across the tissue. So we would do that along with treating that tissue with different nasal medications, nasal steroids, nasal antihistamines, Afrin, saline, and then we tried Zicam. And the research was published in PLOS One, and we show that the Zicam does completely destroy mouse and human olfactory tissue. So it was a pretty big study that led to a lot of issues. And we then saw this, I saw this in my local grocery store, discontinue merchandise when Zicam was pulled from the market. They still sell a different version of Zicam now with eucalyptus and oxymetazoline and I think menthol as well, but the original Zicam zinc-based one is off the market. Numerous lawsuits, very, there's a class action as well, a multi-district litigation, and then a lot of other individual lawsuits that, because of the research I did with Dan Storm, was the lab director. We were expert witnesses on numerous cases, and that's what really started my interest in olfaction.
Greg, so, just interrupt you for a second.
Of course.
How do you get a drug like that on the market with such obvious danger? What's the process, or is it very liberal since it's not an ethical pharmaceutical?
So zinc is considered homeopathic, and there's a homeopathic list of drugs or compounds that can be sold as homeopathic, meaning, they don't have to go down the FDA regulatory pathway whatsoever. And Zicam would have been fine unless you say, make a claim such as it's going to decrease the duration of the common cold. And that's what makes it a drug, by making a claim that it actually treats a condition. So you can sell anything you want. That's in the homeopathic dictionary, including zinc. And that was one of the biggest problems. The other interesting thing is towards the end of all these lawsuits, we finally got the slide presentations from the 2 key scientists for Zicam. And about 6 years ago, before it was pulled from the market, their own scientists reported that Zicam destroyed olfactory tissue in mice when they did the research studies. And the makers of Zicam decided to suppress that information and not tell anybody. According to attorneys, all they would have had to do to avoid lawsuits would have been to put a warning label on there that this may impair smell function in mice. But they didn't do that as well. So that's how it got through the FDA. And that's why you see a lot of things on the store shelves that are making claims. It just doesn't go through the FDA. And unless the FDA gets a lot of warning or adverse events, they don't go after these small companies. All right, let's get into olfaction. So there's just some definitions here. Hyposmia is partial smell loss, and very, very common. Anosmia is total smell loss. A couple more less common ones you may have heard of: parosmia. That's really a distorted sense of smell. It's fairly synonymous with dysosmia. So if patients just say, well, that coffee kind of smells like chocolate, it's not quite right, then that's parosmia. Phantosmia is interesting. Phantosmia is when a patient will smell an odor that is not physically present, that nobody else can smell. And unfortunately, this is pretty common when the olfactory system gets injured and then starts to regenerate. And phantosmia, it never presents with a pleasant odor. It's usually a burning smell or cigarette smell. It's very, very hard to treat other than just giving it time, but we'll get into the treatment shortly. And then cacosmia is the strangest one. And that's where they can smell the odors, but they just can't identify what it is. So it's not so much smell loss. It's more cognitive based, and they're smelling coffee, but they cannot connect that coffee smell to what coffee actually is. I rarely see this. If you take a look at healthy humans, and this study just came out in 2018, pretty big study. If you take a look at healthy humans, average age about 40, 15% of those people will have hyposmia, so decreased sense of smell, and 5% will have total anosmia, or complete lack of smell. However, everybody over age 65 is going to have measurable decrease in smell function if you measure it with an objective test. And the humbling thing is, when you look at the natural history of post-viral olfactory loss, we used to say that 80% of people would regain their smell function in 1 to 2 years. That was what the original study, or classic study that came out in early 2000 showed. But this larger study in 2018 showed that only 40% of patients improve, almost 50% had no improvement, and then 16% worsened. So this really kind of highlighted, like, we need to find something better, find a way to treat these patients. And a lot of the reason that smell function doesn't get better is there's very little known ways to treat these people. So we'll get into the causes. Post-viral, and with COVID-19, it's now pretty commonplace for everybody on the planet to know that COVID can cause olfactory loss. We've known this for decades, that all cold viruses, common colds, coronavirus, and other viruses can cause olfactory loss. It's just COVID tends to do it more than others. We'll talk about why in a minute. My bread and butter, chronic sinusitis and nasal polyps, that's certainly one of the most common causes of olfactory loss. Trauma to the head. So if you have a concussion and the brain shifts anterior and posterior or side to side, it shears off the olfactory nerves coming through the olfactory cleft. That is a cause of usually permanent olfactory loss. Intranasal drugs, certainly cocaine and anything else. I've seen a rise of younger people snorting crushed Tylenol, and it just absolutely destroys the inside of the nose. They claim that they get a high from it. I don't know how that would happen, but they do. Hypothyroidism is one of the reversible causes of olfactory loss. And then neurodegenerative diseases, so things like Parkinson's, ALS, those are all things that you kind of need to be thinking about when you see these patients. And as I said earlier, aging is a natural cause of olfactory loss. Then Kallmann syndrome is where patients are born without the olfactory bulb, as well as some other neurologic issues related to it. Very, very uncommon. But if you see a young person or someone who says, I've never been able to smell, those patients should get an MRI scan to look to see if they have presence of the olfactory bulb. There's, over the last 2 years, a fair amount of research has gone into olfactory loss, and there's been some biopsies on patients with post-COVID-19 olfactory loss. And what happens is the supporting cells, so not the actual kind of stem cells in the olfactory system, but the Bowman and cystinicular cells are what get infected. and it uses the ACE2 and the serine protease 2 proteins to enter the respiratory cells. There are some early investigations into whether or not drugs to treat those pathways would help block the smell loss, but those have not been reported yet. And what happens in most patients is you get inflammation in the olfactory bulb and the cleft, so two different areas. And looking at this MRI, I'm hoping you can see my arrow. You see this is a T2 weighted coronal MRI. You see the olfactory bulb here and here, and there's the CSF that surrounds it. And then right in this area next to the olfactory bulb, which is actually in the sinus space, is the olfactory cleft. So the olfactory cleft really sits between the middle turbinate and the nasal septum high up in the nasal cavity. And that's where the vast majority of the olfactory cells are. It extends back into the superior turbinate, but about 80% of the olfactory cells live along the superior, really top 1 centimeter of the septum. All right, so when you're seeing a patient with olfactory loss, the onset is really key because that helps you figure out what to do as a next step, obviously. So what's the duration and what kind of symptoms did they have? Did they have a concussion? Did they have a virus? Were they sick at the time? And then what's the trajectory? And I'm really into trajectory for all different diseases. Is a patient getting better, staying the same, or getting worse? If they're getting better, you probably don't have to do much. If they're getting worse or staying the same, that's when you intervene. And think about hypothyroidism, cold intolerance, fatigue, brittle hair, or weight gain, dry skin. And then the neurodegenerative conditions, I always ask them, have you had any memory issues, any trouble buttoning your buttons on your dress shirt? Pretty uncommon to pick up a neurodegenerative condition because of olfactory loss, but it does happen. And I've probably once a year, I'll send someone to a neurologist for additional workup. And the taste dysfunction, that's the thing that's so odd, is the taste is so much linked to our olfactory system. So COVID-19 and other issues do not affect our taste nerves, but because it impacts the smell function and how that connects in the brain, patients almost always report a taste loss as well as their olfactory loss. From a physical exam standpoint, looking in the nose is key. Really, you need an endoscope to see at least the middle meatus, where the middle turbinate, head of the middle turbinate, not the inferior turbinate, but where the head of the middle turbinate sits relative to the sinus openings. I cringe when a patient comes in and they said, yeah, my primary care doc looked up my nose and said I had a sinus infection. And as a rhinologist of 15 years, I cannot look in someone's nose with a nasal speculum and a headlight and tell if someone has a sinus infection unless they have horrific grade 4 out of 4 polyps that are almost coming out the nostril. Saying that there's inflammation in the turbinates, I think, is a disservice because that doesn't mean anything. They always look big and swollen and red or pink. But when you have an endoscope, you're able to look at the middle meatus. You can look for polyps, or you can look at pus or ulceration or even just edema, and that can establish the diagnosis of chronic sinusitis. Clearly, a full cranial nerve exam is indicated. Rare to pick up any condition with that, but it's important to do. This, you may be asked to objectively test smell function. And this test, called the UPSIT, or the University of Pennsylvania Smell Identification Test, is the easiest thing to do. And you can buy it through sensonics.com. The test costs about $27 each. I stack them here in our clinic. When patients come in with smell loss, if they're on the schedule, my staff will call the patient, have them come in about 20 minutes early to do this test. And it's just like a scratch and sniff test, just like the scratch and sniff stickers we had as kids. There's 40 different items that they smell. And you can kind of see this first one, they scratch this little box and then they have to pick, it's a forced item, pick whether or not it smells like gasoline, pizza, peanuts, or lilac. And it's nice because it will give you a gradation of how severe the smell loss is. It will also it's kind of a stinger test, meaning if someone is malingering, this will pick that up. Because there's 40 items and you have to choose one of 4, by chance alone, the patient should get 10 out of 40 correct, even if they can't smell anything. So the test is validated that if the patient gets 5 or less correct, then they're likely malingering. And occasionally attorneys will call me and ask me to assess patients with smell loss. And this is one of the things that we'll give the patient. And now and then a patient will come in and they'll only get 1 or 2 right. And I'll say, this just isn't adding up. I want you to come back another day and let's try this test again. So I'm not going to come out and call them a cheater or anything. I wouldn't do that, but I would just say that the test is inconsistent.
But Greg, I don't get it. If they get 5 or less, they're malingering. I mean, if they can't smell, they have to choose something. So why?
Yeah, they have to choose 1 of 4. So by chance alone, you should get 10 out of 40 correct.
Even some people just say, I don't smell anything.
Oh yeah.
I can't choose.
Well, they have to, even if, and I tell them, and they have to guess. That's how this test was validated. So even if you pick A for everything, if someone is truly anosmic and they just want to pick A for everything, they're going to get roughly 10 out of 40 correct.
I get it. Okay. Thank you.
Sure. So this is an identification test. It's measuring whether or not you can smell, again, pizza or lilac at a set concentration. And in research with olfaction, that's not really the best way to study it. It's just the easiest way to study it. And think about it like a hearing test. When you've had a hearing test and when we do audiograms on patients, you get a tone that's presented at a certain decibel. And then that tone, it's the same frequency, but then they're going to change the decibel. It's going to be louder if you can't hear it, or it's going to get quieter. And that's a threshold test. It tends to be more sensitive to change when you measure threshold. So it's not just identifying that sound, or in this case, the odor, it's identifying how faint of a smell can you smell something. A lot of patients with olfactory loss, if the odor is really strong, they can smell it. But if it's very faint, they can't smell it. So the way to test that is with this thing called the sniffing sticks. And this is a really neat test. Unfortunately, it takes about 45 minutes to thoroughly go through with the patient. So it's used only for research purposes. We've done it with a couple of our research studies, and it takes a dedicated research assistant or nurse to go through. And essentially, you see these sets of 3 pens, and one of those 3 pens has the odor in it, and the patient's blindfolded, and you present each 3 of those pens to the patient. They have to tell which one of those pens has the actual odor versus no smell. And so it's a way to present it in decreasing odor concentrations. And again, it's picking up that threshold, which for research, when we're really trying to find something that helps, this tends to be a little bit more sensitive to change. I would not suggest you getting this kit and keeping it in your clinic, though. Go with Upsit from Sensonics. And I have no interest in Sensonics whatsoever. It's just the only one that you can get that's off the shelf. This is a question that whether or not to get imaging comes up a lot. And you're with imaging, you're always thinking about, well, what is it? And having a good kind of pre-test hypothesis will help you decide what you should do. Should you get a CT scan? Should you get an MRI scan, or not any scan? And it kind of comes down to what your thought process is. If you're thinking sinusitis, so if they have nasal congestion, drainage, sinus pressure, and a history of sinus disease, then get a CT scan. And as you'll see, I wrote CT maxillofacial, and my request to this group is, if you are going to get a sinus CT scan, get the CT max face. That's the more detailed CT scan that has thinner images. And the reason is, if this patient ends up going to surgery at some point in time, odds are we're going to need the finer detailed CT scan so that we can use image guidance or 3D navigation during surgery. If you just request a screening sinus CT scan, you're only going to get about 45 images. It's good enough to make the diagnosis, but it's not good enough to use for image guidance. And so if the patient ends up then going to see a sinus surgeon and then they need sinus surgery, they're going to have to get another CT scan. So it's less radiation and more cost effective if you just get the CT max face onset. And in fact, it's the same amount of radiation, whether or not it's CT max phase versus screening CT scan. It just is different in how much data the radiology department stores and how many images the radiologist has to look at. So it is a little bit more expensive, but it is the same amount of radiation. If you're thinking of neurologic disorder, neurodegenerative condition, or headache disorder, or trauma, you should get an MRI with contrast with gadolinium. And then if it's COVID, then the question is, well, what do we do? If the patient says, yeah, I had COVID, I lost my sense of smell, well, what do you do? And we actually have some answers with that now. There was a systematic review that was published just a couple months ago, and it looked at patients with post-COVID-19 smell loss. 31 studies, only 305 patients in 31 studies. So this kind of shows you the power of ENT surgery or ENT research. It's not all that great for it to take 31 studies to get 300 patients, but they pooled data for MRI, CT, and PET CT scans. In the vast majority of cases, everything was normal. The olfactory bulb was normal. The olfactory cleft was normal. And if they did see anything, there was just a little bit of mucosal edema in the olfactory cleft. Remember, that's in the sinus tissue. That's not intracranial. That's not the olfactory bulb. Interesting, patients with long COVID smell loss, they do have a decrease in size of the olfactory bulb, and it does correlate with decrease in smell function. So that's kind of the data. And then this nice group, our friends across the pond, the British Rhinologic Society, made a consensus statement that says an MRI or CT scan is not indicated for post-viral olfactory loss, regardless of the duration. So if you have a patient who had COVID, lost their sense of smell, there's no reason to do any imaging unless you're suspecting something else like chronic sinusitis at the same time. All right, so how do we treat olfactory loss? And it really doesn't matter if it's COVID-19 olfactory loss or non-COVID-19 olfactory loss, but specifically early on, and I know this group will know more about it than I do, there was concerns about using systemic corticosteroids in COVID-19 patients. So the question came down, well, should you use it if these patients have significant olfactory loss? A group published, again, small numbers, classic for ENT research, 18 patients who had COVID-19. They were over 1 month or 30 days past the onset. And the issue was whether or not to do prednisone plus a steroid irrigation. So they were doing a 15-day prednisone taper at 1 mg per kg per day, plus a steroid irrigation. They also added a mucolytic to it. And this is a British group. The asterisks on steroid irrigation, so it's very common for us to use budesonide as the steroid with irrigations. The research, and this is for patients, I'm sorry, digressing here. This is patients with nasal polyps and even with inflammatory sinus disease that don't have polyps yet, just a lot of edema. So rather than using a nasal steroid spray, most ENTs will use budesonide plus a saline irrigation in the irrigation, because as the research shows, you have to use large volume irrigation to flood the sinuses, and very little fluid gets into the sinuses if the patient hasn't had sinus surgery, but it still is worth using, especially when patients have huge polyps. The nasal steroid spray is just going to bounce right off it and not penetrate deeper. And so if you add the steroid to the irrigation bottle, that 240 cc's is going to work its way deeper. One nice thing is a compounding pharmacy over in Paulsville called Cascade Specialty Pharmacy. They're actually just starting to make they're going to use mometasone instead of budesonide, which mometasone is more lipophilic. It gets absorbed by the tissue better than budesonide. It's what's in the same drug in Nasacort or Nasonex, Nasonex. And they're going to add the powder to the salt packet and make it one nice packet. And I can't wait. And my patients are like, oh, I'm so sick of mixing two things together. So if you have any interest of using that pharmacy, just let me know. Again, I have no financial interest with them, but it's called Cascade Specialty Pharmacy. Nice group of people over there. All right. So what did they find? They found in the treatment group, the main outcome measure was this thing called the Connecticut Chemosensory Clinical Research Center, and it scored 0 to 100. Higher score means better olfaction. And in the group that got the prednisone plus the steroid irrigation and mucolytic, they went from a baseline of 10, which is horrible. 20 days out, they improved to 70. 40 days out from onset of treatment, improved up to near normal, versus the control group. They also had a significant amount of improvement from 20 to 20 and then actually 60. So this is a significant number between 60 and 90. But it shows the natural history. And again, most of these patients are doing better after 1 to 2 months. So it's that, this is why it's so important when you're seeing patients with olfactory loss, or when you're doing research on patients with olfactory loss, to have a control group. There's been dozens of compounds from caffeine and other interesting compounds that have been studied in cohort studies, and they always get better with time. Doesn't matter what you give them, patients are going to get better. But then when you do a randomized trial and have an actual control group, most things don't pan out.
Right. The control was irrigation without systemic steroid?
The control group was just saline irrigation. So no prednisone and no steroid irrigation, no mucolytic with it. Basically standard of care. I'm looking at, this is a different study that, again, all this stuff was just published within the last few months. So non-hospitalized COVID-19 patients with smell loss, 5 weeks past the onset, 9 patients got oral steroids plus olfactory training, which we'll talk about shortly. 18 patients got just olfactory training. And I should probably talk about olfactory training, but that's going to be the next slide. They got 10 days of 32 milligrams of methylprednisolone. And what this graph shows is that the group that got olfactory corticosteroids plus olfactory training increased by 7.7 points. This TDI score, that's the sniff and sticks. That's a sensitivity score or a threshold score. And 7.7 is pretty significant improvement, versus just doing olfactory training only increased by 2 points. So the olfactory training alone was not great in these patients. You add the corticosteroid and they improved significantly, both statistically and clinically. And the thought process is that's hitting, the corticosteroids are hitting that inflamed area in the olfactory cleft. This is the only thing, so olfactory training is the only thing in post-viral anosmia or hyposmia that has been shown to help patients, and it's called olfactory training. It's really simple to do. There are a lot of kits that you can buy on Amazon. This kit by Moxie is only 18 bucks now. It's just 4 essential oils, and you can see which ones are right here: rose, eucalyptus, lemon, and clove. All you do is smell each odor for 15 seconds twice a day, and you do that for 6 months. One study shows that if you rotate the odors after 3 months, that it helps a little bit more. But in all the research that has been done for olfactory loss, olfactory training is the only thing that has shown to be helpful. True story, when COVID-related smell loss became known, I bought one of these kits from Amazon. It was 30 bucks a year and a half ago, and now the price has come down because there's other competitors. And I kept it at home knowing that eventually someone was going to get COVID-related smell loss. And my 2 kids are in college, so they got it long ago. But then my daughter got it again and brought it home and gave it to my wife and I as a President's holiday weekend gift. We both did great, but my wife had smell loss related to it, and she started using this smell loss kit that we had, and her smell function bounced back after about 7 days. Now, whether or not that would have happened had she not done this is tough to say. But the nice thing was she actually could tell that her smell function was getting better by smelling these things. So it kind of was reassuring to her and gave her some peace of mind that things were getting better because she was able to smell those odors. So whether or not it's actually helping with the regeneration of the olfactory system, or it's just giving the patient some peace of mind that they're actually doing something, is worth it. And I would encourage you to talk to your patients about this. Now, telling your patients how to do it, I have a sheet. If you email me, I'm happy to send it to you, that spells out specifically what to do. I have this kit written out. I have the instructions: smell it 15 seconds twice a day for 6 months. Because if you don't spoon feed these patients. And if you tell them just go get 4 essential oils, they're not going to do it. You really got to be very specific with it. I want to show you the research behind it. This study, Thomas Hummel, he is the most famous olfactory researcher out of Germany or on the planet. Super, super nice guy. He's been a good mentor of mine over the years. Hundreds of research studies on olfactory loss and very few that are positive. I don't know how he keeps going, but he does. 144 subjects on this were randomized, and half of the subjects had high concentration of odors of those 4 compounds. The other half had low concentration of those odors. So really hard and very faint to smell versus really strong smell. And they showed a bit of a difference in those 2 groups. So in the high concentration group, 20% of the patients improved their smell function versus only 15%. And that alone isn't super exciting. That's hard to get jazzed up about. But when you look at the patients who lost their smell function within the last 12 months, that's where the significant difference was. And you can see 63% of those patients improved in the high concentration group versus only 20% in the low concentration group. What this tells us is that early intervention of smell loss is important. And it's true with sensory neurohearing loss. It's true with a lot of other neurologic changes that if you intervene early, that you can make a difference in the patient's outcome. So seeing the patient, getting them on board with this sooner than later should help them. There was another study. This is the one that looked at rotating odors after 3 months. 85 subjects with post-viral smell loss were, I don't like this part, they were arbitrarily assigned, so it wasn't randomized, which is odd. I think that patients were allowed to pick what version they wanted. The classic version is olfactory training, same odors for 36 weeks. As I said, rose, eucalyptus, and lemon and clove. And then the modified olfactory training switched those odors. And they did that every 3 months. They show, and then there was a control group with no olfactory training. And so this graph, the score here is smell function, and then this is time on the x-axis. And the modified smell function group had a significant improvement, even more so than the classic olfactory training. But both those groups did quite a bit better than the control group. So again, olfactory training works. It's easy to do. It's safe. There's no side effects from it. The hardest thing about it is the time and dedication. And I tell my patients the easiest time to do is when you're driving to work and driving home, as long as you're not distracted. It's just a dedicated time where they have their kit right there and they're just smelling their odors while they drive to work. Oh, well, I gotta throw it
over.
I know. I always think that someone's going to call me and say, well, I got pulled over because I was smelling these things. And yeah, it hasn't happened yet. I have to throw in a slide about sinus surgery. No surprise, coming from the biased surgeon. So a friend of mine, Tim Smith, and one of his residents did this research study. And this mean SIT score on the y-axis, this is a smell identification test. So this is the upsit. It scored 0 to 40, and 40 is normal smell function. Anything below about 15 is complete anosmia or complete smell loss. And they looked at patients after sinus surgery, both with and without polyps, and normal versus hyposmic patients versus total anosmic patients. So this is important from my standpoint, and hopefully yours as well, but how we advise patients who want to have sinus surgery and have some smell loss. And if they have normal smell function, whether or not they have polyps or not, it doesn't really change over time in a year. It's interesting that there is a decrease in smell function. That doesn't surprise me because I think there's a lot of inflammation that happens due to the trauma of sinus surgery, and that edema will decrease patient smell function. I guess what surprised me is that it only drops off by 2 points on average. I would expect it to go a lot lower. When you look at patients with partial smell loss or hyposmia, again, same thing. They have some impaired smell function and they end with some impaired smell function. It's a little bit better from 28 to 30 if you have polyps, but that's not a clinically important difference. The minimal important difference is 4 on this scale. But if they have complete smell loss, which usually means they're they're super packed with polyps. That's the orange line here. They go from a 9, which is complete smell loss, and they get up to 23, which is still significant smell loss, but at least they can smell some odors. And that's a huge improvement in quality of life if you can take someone from no smell function to even a little bit of smell function. And it's interesting in patients, even without polyps, that they got significantly better as well. That's the green line here. So I tell my patients if they have smell loss, if it's complete smell loss, they should get some improvement after surgery. If they have partial smell loss, I tell them that they probably won't get a lot of improvement. It's based on this study. So other interventions, Yvette was nice enough to help me out with this. This is a paper that was presented at Quad AI, or sorry, a poster that was Quad AI, and one of the main mepolizumab studies, and 407 patients were randomized to mepo versus placebo, and they were assessed with a 10 centimeter visual analog scale, compared baseline versus week roughly 49 to 52. And it showed a significant improvement. So if you look at the change from baseline, this 3-point improvement, which is actually a 30 out of, or a 3 out of 10. So that's a clinically and statistically significant improvement versus placebo. They did have improvement in their smell function. And these are usually going to be patients with polyps. Sorry, all of these are patients with polyps. And then the percentage of patients who improved, looking at the odds ratio, 36% chance that they're going to get greater improvement or greater than a 3-point improvement versus 19% chance that they're going to get a 3-point better improvement. So that's, again, important to, when you're talking about mepo and the biologics and patients ask about their smell loss, are they going to get improvement in smell function? The answer is they should, and it's likely related to the decrease in polyp size. Sodium citrate spray. This is an interesting one. This was a randomized study done by Dr. Hummel and his group. And this is one of the few other things. I'm only going to show you things that help patients. They did 61 patients with what's called non-conductive olfactory loss. So not polyps, not huge inflammatory sinus disease. We consider that conductive, meaning the odor is just not getting to the olfactory cleft. They used a 0.5 cc's of a 9% sodium citrate spray, and the control was just saline. And it was just in a simple saline type of spray bottle. And the interest was, an interesting thing, they measured the olfactory function every 15 minutes. And I don't know the mechanism behind this, but what they found is in 2 of the odors that the sodium citrate spray significantly improved the smell function, and that smell improvement peaked 40 minutes after the spray, and it returned to baseline within 120 minutes. So it's a very, very short acting compound. Unfortunately, 30% of people get a runny nose and a sore throat from it. So when this study came out in 2018, I was pretty curious, and I started prescribing it through the compounding pharmacy, Cascade Specialty Pharmacy in Paulsbo. And they mixed it up exactly how they did it in this research study. I only submitted 8 prescriptions. And then I asked the pharmacist to give me I should have done it as a research study, but I didn't. I wanted to see if it worked first. And I was thinking about using this as pilot data. So I just went back and asked the pharmacy about a year later. I said, okay, of those 8 people that I prescribed, how many patients refilled it more than 2 times? And the answer was 3. I'm going to figure if it's not, because it's such a short acting thing, if it's not helping patients, they're not going to refill it. So, it's, right or wrong, 3 out of 8 patients decided to keep using it. And what they would end up doing is they would use it before they're eating or before they're cooking, because it did improve their smell function short term. And evidently they liked it. Sodium citrate spray, getting back to like the Zicam model, that's just one of the homeopathic medications. So you don't have to go through an FDA approval process to sell sodium citrate spray. Now, if on the bottle it says this improves smell function, you would have to go through the FDA process. All right. Theophylline, a PDE inhibitor. Theophylline has anyone, I don't know if I can even see hands. Len, have you ever, since you're talking, or Drew, have you ever prescribed oral theophylline?
Not for this indication, but yeah, we used to use it, somewhat frequently when I got into this field. Very, very rarely now for asthma.
Right.
Yeah.
Severe asthma and severe COPD. And the reason it's not used is there's a lot of side effects. So it's a drug that's very similar to caffeine. When the drug levels are a little high, you get the sensation that you've drank way too much coffee, and then you can get systemic toxicity. It has a ton of medication interactions, as you can see from this little graphic here, 45 major drug interactions that if they happen to be taking that drug at the same time, it really spikes the serum levels of theophylline. And it's a lot of very common things, even like azithromycin. The thought is in the olfactory system, it uses calcium gated ion channel is the main signaling pathway for the nerve to transmit the signal. And so you get the odor that comes in, you get these little breakdowns of cyclic AMP to AMP, and theophylline is going to inhibit it's a phosphodiesterase inhibitor. So it's going to inhibit the breakdown of cyclic AMP to AMP, which is needed to open that calcium gate. So the thought was, if you block that, you're going to have improvement or a sustained duration of signal from that neuron. And this guy, Robert Henkin, who's a neurologist, he's in his 90s now over in Washington, D.C. He's been doing olfactory research for a long time. He does have kind of some interesting methodologies, which is what makes it a little challenging to adopt what he recommends. But his research study on, I think it was 300 patients, showed a 17 to 53% improvement. And he showed a dose response that if he would start the patients at 200 milligrams of theophylline and about 17% improved. And if they didn't improve, he would escalate it to 400 milligrams, more people improved. Then if for the non-responders, he would keep escalating up. And at 800 milligrams, over half the patients improved. There was no good control. There was no control group at all in these patients. And it was all types of comers of olfactory loss, from traumatic, post-viral, idiopathic, neurodegenerative. And so this never really was picked up. Plus, because it's such a hard drug to prescribe, I initially wrote an R01 to do this as a randomized trial, and that didn't get funded. Not a big surprise. And just as I was about to submit a revised R01, this study came out that they used intranasal theophylline, so a theophylline nasal spray on 10 patients. And their main outcome was this subjective outcome measure 0 to 100. It's the same group of people by Dr. Henkin, and they showed that 30% improved greater than 5 points. Now, a 5-point improvement on a 0 to 100 scale is not a lot to write home about, but that's what their main outcome measure was. So I revised my R01 to use, and I was writing it up to use intranasal theophylline, and then for various reasons, I didn't submit it. My research took a different direction, but I prescribed it in 14 patients. And a year later, I asked a pharmacist, just like I did with sodium citrate spray, how many patients are still using it or refilled it more than one time? And the answer was 4. And I've spoken to some of those patients, and there's a couple of them who swear by it. Like, yeah, it really helps. There is one of these 10 patients is a venture capital investor from Silicon Valley who lost his sense of smell, and he traveled to visit Dr. Henkin, used the intranasal theophylline spray, and he had complete return of his smell function that had been lost for over a year. So he invested a bunch of money, formed a company, and now this company is starting a randomized trial. We'll be one of the clinical sites. It should start in the next probably 3 or 4 months. And it's just a simple study that's using the intranasal theophylline. It is going through the FDA approval process. So this is going to be a phase 2 study. Kind of exciting because it doesn't get, intranasal theophylline does not get absorbed to any measurable level systemically. In those of those 14 patients that I prescribed it on, the first 5, I did get serum theophylline levels. after 3 days of using it, and it was always undetectable. If you really want to read about olfactory loss, myself and about 75 of my colleagues just published a 354-page report on olfaction. The executive summary will come out in another month, but this is in the International Forum of Allergy and Rhinology, and it just combs through every type of research with olfactory loss. This is called the ICAR updates, and there's an ICAR update for olfaction, for skull base surgery, for chronic sinusitis, for allergies. There's a lot of allergists in here as well. So to summarize, it's key when you see these patients, evaluate for non-viral factors. If it's just COVID-19, well, let's talk about the non-viral factors again. Chronic sinusitis and hypothyroidism, two things that we can actually fix the olfactory loss pretty easily. Imaging is usually not necessary for post-viral anosmia. Do recommend a short course of oral corticosteroids, as well as a steroid saline sinus irrigation. And the most common is with budesonide, whether or not you prescribe it through a compounding pharmacy or your local CVS, as Pulmicort is fine. And you just tell the patient, mix the Pulmicort with the salt packet in the 240 cc sinus irrigation bottle and squirt it up your nose. Always remind patients to use the salt packets when you're using any type of medication with the irrigation, because it's the salt and the baking soda pH balances it out so it doesn't sting when you squirt it up your nose. If you don't believe me, try squirting plain water up your nose and with and without the salt packet, and you'll realize the salt really helps make it easier. And then olfactory training. That's something that I hope you guys take to heart. And when you see a patient with olfactory loss, or yourself or your friends or family, then ask them, tell them to Amazon a kit and get at it. So I think in the interest of time, we have 10 minutes. I'm not going to have enough time to go through the systemic steroids for nasal polyp talk. We can do that another day. Len, if you agree with that, I would love to just take some questions and talk sinus talk or olfactory loss, if you're okay with that.
Yeah, I think that's appropriate. That was brilliant. I had, all the years you've spoken to our group, I never knew you had this interest. And I don't usually think of sinus surgeons diagnosing hypothyroidism. So that's a real pearl. I have one question. So as elderly people, myself being one of them, who's lost most of their sense of smell just due to aging, do you just accept that, like lots of everything that fails when you get older? Or is there anything to be done about hyposmia from aging?
There's one study that looked at patients over age 60 and did olfactory training. It wasn't a randomized study. That's why I didn't present it. But of the patients over 60 who did olfactory training for non-sinusitis reasons, there was a significant improvement, clinically significant improvement with the olfactory training. So I would encourage you to try the olfactory training for 3 months and see what you think.
The kid from Amazon.
Yeah.
I saw one, Jay Springer wanted to know what the word of the day was.
Oh yeah, good call. It's spring. Where'd my slide go? I don't know how to. Yeah, it's spring. Why can't I?
It's pretty cold for spring, but.
Well, I found it. Let's do this. There you go.
All right, word of the day is spring.
Word of the day is spring. Although dandelions don't come out quite yet, do they?
Other questions?
Hi, it's Arvin Mocha. Quick question for you. The Amazon kit, is there anything unique about those 4 common smells there, or any 4 type of smells will do?
Hey, Arvin, nice to talk with you. I know we've shared a lot of patients over the years. I always appreciate that. Are you still at Virginia Mason?
No, polyclinic?
Polyclinic. Okay, sorry. The rose, eucalyptus, lemon, and clove, they are, they're unique in that kind of there's some are sweet, some are not sour, but they're different varieties of smell. And you can get these essential oils at your health food store or Whole Foods. It doesn't matter. It doesn't have to be a kit from there. But I tell patients, like, these are the 4 odors that were studied in the research studies, and that's what I would use.
Thank you.
Greg, the people who come in to see you, I've just always thought of you as a sinus surgeon, people coming to you basically when surgery is necessary. What percentage of people do you see for smell disorders and you don't operate on?
Yeah, I probably remember surgeons were smart once upon a time. So we used to use our brain. I see at least one patient a week with who comes in just for smell loss, which isn't a lot. And part of that is just because of the research I've done, and patients will look up and they'll find my name, and usually that's how they track me down. Certainly when this research study kicks up, we'll be advertising more, because that's going to be I think it'll be fun to do this research study. Except we're using the sniff and sticks, so it's going to be a long visit for my research nurse down here. But I enjoy seeing these patients, the smell loss patients, and a lot of it is, I know there's conditions you guys treat where no one else can fix it, and you're kind of the last resort, and that's similar with olfactory loss. The primary care docs don't want to handle it, or they don't know what to do. Neurologists don't know what to do, and you would think they would have a better understanding of this, but there's nothing in there, very little in their journals about olfactory loss. It's almost all in chemosensory ENT type journals. So I'll get referrals from neurologists as well. And it's kind of fun to say, look, this is what you have, this is what you don't have. And there is something that you can do yourself that's safe to try to make you feel better. And that's kind of nice.
Is there anybody at the university with expertise?
Not right now. I mean, Ian Humphreys is fantastic. Arya Jafari, they're all great, and they all should know about olfactory training. I'm sure they all do, especially Ian and Waleed, who trained at Stanford, where some of the olfactory loss research was done. And then Arya Jafari, who he presented, he's the newest rhinologist at UW. He presented to this group, I think, just a month ago or so. I thought I saw he present. I may be wrong, but he trained with a great guy, Eric Holbrook, over in Massachusetts, and also has an interest in olfactory loss. So I think that would be a fine resource to send patients to as well.
Other questions? We still got 30 plus people listening. I think I found that a fascinating presentation. I'm very happy to know that you're available for people with this problem, because I think most of us think about polyps as the cause and not much else, and really don't know what to do for these people. So I'm glad to know you're an expert resource in the community.
Always happy to see any patients, including these patients. And again, once you kind of figure out the pathway of how to take care of them, it gets pretty straightforward to work them up. And again, a lot of times you find chronic sinus disease. So unless it's post-COVID, I'm generally getting a imaging study on them. I like looking around the board and seeing the allergists from around town and Eastern Washington. I see Trevor, you're on there. Thanks for taking care of patients over on the other side of the mountains.
Yeah, no, we've got a pretty broad audience here.
What's the
Right.
what's the decision to start meeting in person as well as continuing online? How's that looking?
Well, I think we'll finish this year online, and then, I mean, it's not up to me. I think it obviously up to the University of Washington when we can use facilities, but I was going to definitely ask to start doing it in September for next year, assuming that the pandemic continues, we don't get another variant. You know, just yesterday, Philadelphia decided to go back to have a mask mandate again because of a slight uptake in cases. So it's obviously, as we're all aware, it's a fluid situation, but it looks like I think we could meet in person starting in September.
Excellent.
So we'll have you do that next year for sure, one way or
Happy to.
another.
Yeah.
All right. Thanks very much. I know you have a case.
All right. Thanks, everybody. And again, word of the day was spring, if you missed it. Have a good day.
All right.